Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day. Hi, all you BTK listeners. It's Scott here, and I want to talk a little bit about our BTK colorectal surgery oral board audio review. With upwards of 50 plus high-yield scenarios designed for colorectal surgeons by colorectal surgeons. These scenarios are 5 to 7 minutes long. They got a variety of tactics and styles. We also have a high-yield commentary to each scenario that includes tips and tricks that'll help you dominate the most challenging of scenarios. In addition to practical, easy ways to think through, easy to understand teaching style that covers most confusing, most interesting, and the most basic of topics that we all face as colorectal surgeons. So we are highly confident that you will find this unique dual format approach a highly effective way to prepare for your test. And now listen, best of all, every course subscription now comes with access to our revolutionary oral board simulator. You can practice out loud your decision-making under pressure to identify and fix your knowledge gaps before you face the real examiners. Check it out at behindtheknife.org.
Hello and welcome to all the Behind the Knife listeners. My name is Betalin Johannes. I'm currently a third-year general surgery resident at the University of Washington. Today, our team will be discussing one of the most important and evolving topics in rectal cancer care: fertility preservation and pregnancy considerations for patients undergoing treatment of rectal cancer. We're excited to share the latest evidence and practical considerations surrounding this topic. To start, I'll let my colleague, Dr. Allen, introduce himself.
Thank you so much. I'm Griffin Allen. I'm a second-year research fellow and rising fourth-year general surgery resident at the University of Washington, and thrilled to be here to talk about this important topic.
Welcome, Dr. Allen. We're also very fortunate to be joined by two outstanding guest faculty members, and I'll invite them both to introduce themselves as well.
Sounds good. Thank you guys for having us. I'm Dr. Siddharthan. I'm an assistant professor at the University of Washington in the section of colorectal surgery.
Hi, I'm Stacy Cohen. I am a professor of medicine in Division of Hematology Oncology. So I'm a medical oncologist with a focus on GI cancers, especially colorectal cancer. Thanks for letting me join your surgical podcast today.
Thank you all so much for joining us today. We're very excited for this discussion, so let's dive right in. Why is this conversation important? So colorectal cancer is increasingly being diagnosed in younger patients, and in fact, it's now the leading cause of cancer-related deaths for individuals less than 50 years of age. At the same time, more people are also delaying childbearing. As a result, surgeons are more frequently caring for patients with rectal cancer who are pregnant or hoping to preserve future fertility. This creates a new set of challenges. How do we effectively treat rectal cancer while also considering fertility, pregnancy, and maternal fetal safety? Standard therapies like pelvic radiation and surgery can significantly impact reproductive potential and future family planning. We also know that these discussions may not be happening often enough. A 2022 study found that only about half of eligible rectal cancer patients reported discussing fertility implications with their surgeon. So our goal today is to help change that. Through a case-based discussion, we'll explore how multidisciplinary teams balance cancer treatment with fertility and pregnancy considerations in real-world practice. I'll now pass it up to my colleague, Dr. Allen, to walk us through the first case.
Thank you so much. For our first case, we're going to be talking about a patient where rectal cancer is potentially interested in fertility preservation. And so to frame this part of our discussion, we'd like to start with a paradigmatic case. This is patient Y, a 35-year-old with no previous pregnancies who presented to her PCP with senescence and hematochezia, and she is ultimately diagnosed with rectal cancer. Her staging workup reveals a T3N1M0 tumor located 5 centimeters from the anal verge. Based on this, she's recommended to undergo total neoadjuvant chemoradiotherapy followed by potential low anterior resection. Importantly, she is very interested in future fertility and wants to understand how her onslaught treatment plan, including chemotherapy, radiation, and pelvic surgery, may affect her ability to become pregnant or carry a pregnancy in the future. So using this case as our foundation, let's explore some of the consideration. To start us off, I'd like to ask a broader question about fertility after rectal cancer surgery, even outside of chemotherapy and radiation. Dr. Siddharthan, when you're counseling a patient with rectal cancer, particularly a younger patient who may want children in the future, How do you discuss the potential impact of low pelvic surgery on fertility and sexual function for both men and women?
Fantastic question, Griffin. And I think it's something that's really evolved in my practice over the years. It's something that I was not very good at discussing with patients because I think we all get really tunnel vision whenever we're dealing with oncologic cases and really focus on the cancer. And we really don't think about some of the long-term outcomes that we can see from doing any kind of rectal cancer surgery. So in particular for fertility, a lot of our data is extrapolated from the inflammatory bowel disease and pouch formations, so in patients with ulcerative colitis. What we've seen is that basically any type of pelvic surgery can often cause scarring in the pelvis. This scarring in the pelvis will decrease fertility. On top of the scarring that occurs, there can also be difficulties with nerve function, in particular the sympathetic and parasympathetic nerves. These affect men and women very differently. There's a lot of good research for men and the effects of hypogastric nerve injury or nerve area genti injury and the resulting effects on ejaculation. For women, some of that data is not as well pronounced, but there clearly is a significant decrease in fertility with any type of pelvic surgery from any kind of injuries to the nerves. In particular, for the scarring that can happen in the pelvis, that can often impact the ability for the fallopian tubes to work adequately and for fertilization of the eggs. And so those are really important discussions that you have with patients, especially ones who are 35 and potentially thinking about having children, because this one intervention can radically affect their ability to have children in the future. And so when it comes to those considerations, it's often really important that you have a frank discussion with the patient. Tell them that this will decrease their fertility. If they're interested in having future fertility, that there's options that are available to them, whether that be the reproductive endocrinology route with, frozen eggs or frozen embryos, or potentially delaying surgery in some cases in situations where it can be delayed.
Thank you. So even beyond pelvic surgery, I think another major consideration that is often on the top of everyone's mind is the impact of chemotherapy and radiation, which of course is a cornerstone of rectal cancer treatment. And of course, there's a growing body of literature examining how these therapies affect both fertility and reproductive health. Dr. Cohen, could you please help us understand what patients should know regarding the fertility implications of both chemotherapy and, while I know this isn't your specialty, radiation?
Yeah, I think it's a great thing to bring up because, we really think about rectal cancer as being trimodality care. And so we really need to break down all of the components because when we're advising a patient about what type of treatment they might receive, we are thinking about what are those long-term goals and how do we maximize the efficacy and minimize the toxicity. So with this chemotherapy and radiation components, we can break those down and think about how radiation of the doses that we need to give to someone with rectal cancer really do have pretty significant impacts on fertility. Very low dose radiation that you might get like for total body irradiation is not really going to impact fertility, but the radiation that we typically would use, 25 to 50 gray, to a pelvic area is going to cause scarring of the uterus such that someone would be unable to carry a child afterwards. And then there's also, even if you do an oophoropexy trying to remove the ovaries out of the field, that's not always successful. So there can be direct impact to the ovaries as well as to the uterus. And then on top of that, we have the chemotherapy component, and chemotherapy being toxic cell-killing chemicals. We don't want someone ideally to get pregnant while they've been on chemotherapy, or really we advise waiting 1 year after chemotherapy. And we don't know if really we're kind of extrapolating from some of the breast cancer data, but we really don't know like when the magical right time that someone would be safe to try to start having a kid naturally. But we usually advise 1 year. So in your young rectal cancer patient, like the patient that you're discussing now, we typically advise fertility preservation prior and then counseling patients about whether or not we anticipate they would be able to carry a child or would need a surrogate depending on whether they would receive radiation or not.
So with those risks in mind, just to kind of sum everything up and talk about what potential fertility options are, and we've kind of already hit on a few, including oocyte or embryo preservation as well as ovarian transposition. Dr. Siddharthan, how do you approach this discussion of fertility preservation when counseling patients before treatment even begins?
Great question. So again, I think it really depends on the treatment. And this is really a discussion that we have at Tumor Board, oftentimes deciding what is kind of the pathway we're going to do, whether it be consolidation chemotherapy or radiation first. In terms of the different procedures and different things, if they're interested in oocyte preservation, we'll do an early referral to reproductive endocrinology. And oftentimes there can be, whether it be sperm banking for men or embryo cryopreservation for women. And this can be done before we begin therapy. And that probably has the most long-term success, because obviously it's pretty similar to what it would be for somebody who's doing this outside of their rectal cancer therapy. The biggest issue is it requires a procedure, and the timing and coordination of that is often the most difficult part, because you obviously want to start therapy for rectal cancer as soon as you can. Sperm banking is a great option for men and has excellent results. In terms of the procedures that are available, there are ovarian transpositions and ovariouterine transpositions that have been described. And this is something that we've recommended for a few of our patients who end up getting radiation. This is where we basically pexy the ovaries out of the pelvis. This is done by our gynecology colleagues, and there is kind of mixed results. It's a little bit hard to study because it's hard to know sometimes what someone's fertility was before the transposition compared to after. What we have seen is that it is helpful, especially in a situation where radiation is going to be performed for local control of the rectal cancer. There are some discussions about doing uterine transposition. I've never seen this in my practice, but it is definitely something that has been described in the literature. I will say critics of both of these procedures, it's potentially an operation that comes with risks with maybe unclear success rates. And so I think just a formal discussion with your reproductive endocrinology colleagues very early on is probably the most important thing that can be done.
Thank you so much, Dr. Siddharth and Dr. Cohen, for sharing your insights. So to summarize for our listeners, despite the growing number of patients who may desire future fertility, many are not receiving counseling. And it's important because both men and women can face fertility loss and sexual dysfunction, even from just surgery alone. And on top of that, chemotherapy and radiation will add, of course, clear and dose-related risks to future fertility. Early referral to reproductive endocrinology specialists is pivotal and should be the default for all patients of potential childbearing age, with, of course, typical options including egg, sperm, or embryo banking. Even with these strategies, fertility may be challenging, and these pregnancies, of course, even afterwards, may be more complex, may require additional assistance from maternal fetal medicine specialists. But overall, this highlights the need for early, multidisciplinary, and, of course, patient-centered counseling.
Let's move into our second case. To ground this discussion in a real-world scenario, we have a 35-year-old woman in her second pregnancy who presented with several months of hematochezia. Notably, she had experienced rectal bleeding during her first pregnancy as well, but after a first trimester miscarriage, her symptoms improved and no further workup was pursued at that time. During her second pregnancy, however, the bleeding persisted, prompting further evaluation, and she underwent flexible sigmoidoscopy, which revealed a 5-centimeter mass located approximately 10 centimeters from the anal verge. Biopsy confirmed a microsatellite stable rectal adenocarcinoma. Staging workup demonstrated a non-metastatic, clinically stage T3, N1, M0 mid-rectal cancer. So with that clinical picture in mind, a locally advanced rectal cancer diagnosed during ongoing pregnancy, let's walk through some of the considerations for managing this patient. Let's start with one of the biggest challenges in this case, which is diagnosis. Colorectal cancer is less common in young patients to begin with, and now we're layering pregnancy on top of that. Dr. Siddharthan, from your perspective, what makes colorectal cancer particularly difficult to diagnose during pregnancy?
So I think the first thing is that it is obviously extremely rare. It has an estimated incidence of the 0.002%. And so it's extremely uncommon, and it wouldn't be in someone's differential, especially someone who doesn't treat rectal or colon cancer very frequently. Unfortunately, often these patients are also not part of staging or screening guidelines because they're obviously too young to be within the screening guidelines of about 45 years old. That being said, the hallmarks that we always see with, suspicion of a rectal cancer would be rectal bleeding, constipation, anemia, change in bowel habits, abdominal discomfort, and even fatigue. The hard part with pregnancy is oftentimes these symptoms overlap. And I think one of the most common things that gets diagnosed in pregnancy is hemorrhoids. And obviously that makes sense because the increased blood flow into the pelvis during pregnancy will cause the hemorrhoids to engorge. And so sometimes it's hard to know if this is just hemorrhoids and nothing to worry about, or potentially could this be a malignancy. I think there's also a really big psychological burden and barrier when we deal with pregnant patients. We often want to avoid doing anything because we're always very worried about the fetus and preterm labor and different issues. And so I think we sometimes ignore some of the symptoms that the pregnant women express. even if it could be something that'd be much more worrisome in someone who was not pregnant.
Yeah, I think you hinted on my next question, which is there is sometimes hesitation around imaging or endoscopy in pregnancy. So can you walk me through what actually is considered safe and appropriate workup when colorectal cancer is suspected?
Yeah, absolutely. So I think the most important first step is in someone with rectal bleeding is to do a thorough anorectal exam. So that would be an external look, a digital rectal exam, and an endoscopy. This is extremely safe and can be done in any patient. I think the hard part is many people who would be seen as patient, gynecologists and primary care doctors, do not feel comfortable doing this. If you suspect rectal bleeding and you see a large hemorrhoid, you can kind of attribute the bleeding potentially to that hemorrhoid in that situation. If you don't see anything, then that should probably indicate further workup, likely with a flexible sigmoidoscopy. The benefit of flexible sigmoidoscopy is these can often be done without any sedation and can be done in an office with an experienced provider. This obviously prevents any kind of potential impact on the fetus from medications associated with sedation, but also could give you the answer. The other big thing to keep in mind is most early onset colorectal malignancies are rectal cancers, and these would be diagnosed with a flexible sigmoidoscopy. In terms of imaging and staging, MRI is safe for staging of rectal cancers in pregnancy, but you must avoid gadolinium because this can be tetragenic. The other big thing is we often will do CT scans in select situations with shielding of the fetus, especially for a CT of the chest. But like all of these decisions, it's very complicated and requires a formal discussion with the patient as well as a multidisciplinary approach, which I think is the most important thing when you're confronting a patient in this situation.
Yeah, and I think the same goes with when we think about treatment. So before we dive into the pregnancy specific nuances of treatment, I think it would be helpful to ground our listeners in the standard approach. So Dr. Siddharthan, can you start by walking us through the typical management of non-metastatic, locally advanced rectal cancer in the non-pregnant patient?
Sure, absolutely. So, we have three modalities of treatment for rectal cancer. We have chemotherapy, radiation, and surgery. Over a long time with various studies, we've really kind of ironed it out into, for mid to low rectal cancers, the use of total neoadjuvant therapy, or TNT for short. TNT incorporates both chemotherapy and chemoradiation. There is still some debate about whether chemoradiation should be done first, before, after, or second after chemotherapy. This is kind of our standard approach for most stage 2 or stage 3 rectal cancers. For very early stage T1 cancers, we can think about a local excision or a formal resection depending on the location. For anything much more than that, or tumors with concerning features, TNT is almost always recommended. And so for our kind of in general, often patients will get TNT. We'll reassess to see their response and then determine whether or not we'll move forward with a full radical resection versus a watch and wait protocol. Watch and wait is a newer kind of approach to these complicated rectal cancers, and it's when we've seen a complete clinical response from TNT, and we expect this to happen in between 25 to 30% of patients. The key with watch and wait is that the patients need to be watched and wait. I think the biggest issue that we run into or we see is often patients that are told they have a complete clinical response and they don't have the follow-up necessary to make sure that a recurrence doesn't occur.
So building from that foundation, how does pregnancy change the patient? What specific considerations come into play when you're thinking about timing of surgery, the role of neoadjuvant therapy, radiation exposure, and overall treatment sequencing in pregnancy? I'll invite both Dr. Siddhartha and Dr. Cohen to weigh in on this.
Sure, absolutely. So I can start from the surgical side of things. So just from the anatomy of the uterus, as well as having a pregnant uterus, this can obviously obstruct your view of potentially trying to do a surgery. Nowadays, many of us are able to do these surgeries robotically, but obviously if there's a pregnant uterus in the way, it needs to be manipulated out of the way, pushed out of the way, or potentially manipulated. And this can induce labor. And so from just a technical feasible point of view, sometimes these rectal cancers are not resectable when patients are pregnant.
So adding to that, I think there's obviously a lot of hesitancy in treating a pregnant patient. We are certainly seeing this happen more and more as we see the rising epidemic of younger people getting rectal cancer. But I think we have to try and still give the best outcomes to both mom and baby. And so I've seen some cases where patients got diverting colostomies early on out of a concern that they were going to have an obstructive issue during the pregnancy. But actually, we can treat patients fairly successfully with chemotherapy in the second and third trimester. So I have treated several pregnant women for colorectal cancer where they've been able to deliver healthy pregnancies with babies that don't really show any sign of having been exposed to chemotherapy. And so I think, when someone is found in the first trimester, it's actually a little bit trickier. But often these cases present in the second trimester or later. And so what we can do is actually just support that patient with chemotherapy through the time of the delivery in conjunction with MFM and surgery and everybody, and hold off on any radiation, hold off on that full staging MRI that we want to get with contrast, but keep them on chemotherapy, deliver that healthy pregnancy, and then actually assess the status of the disease, likely giving them then chemo, radiation, and surgery, but really making those considerations depending on how everything looks after they've received some neoadjuvant therapy. And this would be a little bit different than our standard patient because often we'll start with chemo radiation. But again, we would not want to give radiation to a pregnant woman.
Yeah. And I think the other big thing that sometimes gets missed in these conversations is if it is an early first trimester pregnancy, a discussion with the patient about potential termination of the pregnancy is really important. I think it's really important that you have that conversation with the patient so they understand that that is an option. Because I think oftentimes it kind of gets skipped. And it's really dependent on what the patient wants for themselves as well as for their potential fetus.
I do want to acknowledge the ethical complexity in a case like this. And while we won't dive deeply into the ethics today, I think when treating a pregnant patient with rectal cancer, there are ethical considerations that need to be at the forefront of our minds. And I was wondering, Dr. Siddhartha and Dr. Cohen, if you have some sort of way of discussing with patients about these kinds of, considerations.
I think the most important thing is just being honest with the patient and having a very frank discussion about what their goals are, whether it be for their pregnancy, for their rectal cancer treatment, and kind of talking through with them the various options. It's obviously a horrible situation to be in, to be diagnosed with a rectal cancer at the time of being pregnant. But I think kind of leveling with the patient and making sure that they understand that there are options and that there isn't guidelines or clear, this is what we have to do in this situation. It's really just having a really frank discussion with a multidisciplinary team and trying to come up with what's the best treatment plan for that specific patient. And so I think coming into it, you have patients who maybe have had children before and they're okay with some decrease in fertility, or the reverse is this is their first child ever and that it's really important that they deliver this child. And so I think it really is important that you have a frank conversation with them so they understand the risks and benefits of each approach.
I would echo that in oncology, unfortunately, we are often counseling patients about situations where they don't want to be in that situation. Maybe they have a metastatic incurable cancer or a poor prognosis. And here it's certainly complex because you're taking care of both mom and baby at that time. But I think that just as Dr. Siddharthan said, we just need to be open to really having that conversation and thinking through the options. And I think when we're most successful is when we acknowledge that elephant in the room and really say, here's what's going on, here's what we can do, and here's what we can't do, and help that patient make the most informed decision in a hard situation.
The patient that we're talking about today is a real world patient that we had. It was her third time trying to have a pregnancy, and she finally got pregnant and was very excited to have the baby. So her goal was to have the baby, and we kind of modified and changed our treatment approach based off of that being her main goal. So she ended up getting chemotherapy during her second and third trimester. She delivered. We restaged her. She got radiation after eating transposition of her ovaries for future fertility improvement. And then she eventually underwent an LAR about 6 months after delivery. So we kind of realized what her goals are, what our goals were for the treatment, and kind of tailored it specifically to what worked best for her.
Yeah, I think you both have highlighted how much of a layered complexity there is in taking care of patients like these and how rare these presentations are. And I'm just wondering, to wrap up our discussion, what your advice is for junior faculty or residents as far as building the comfort that comes with having these complex discussions and the knowledge base around these rare presentations?
What I would say is it never gets easier. This is always a very difficult situation, no matter how many times you see it. And I think that knowing that going into it, that this is going to be complicated, it's going to be hard, it's going to be a difficult conversation is the first step. And then I think, again, I'm so happy that I have a doctor like Dr. Cohen here to help me, because it is the multidisciplinary coordination is the key for taking care of these patients.
And I would echo that. I mean, I think that we are so lucky to have such a well-formed multidisciplinary team. And this is just one example of how complicated cancer care is in 2026 and beyond. But I think that when we are thoughtful about it and really try to think through all of the different issues and opportunities, we can really provide excellent care to our patients, which is fundamentally what we're all trying to do.
I really want to say thank you so much for both of you for sharing your expertise on a complex case like this. I do want to summarize for our listeners. The first is that we don't want to anchor on pregnancy and kind of ignore these persistent GI symptoms that deserve further evaluation. Second is appropriate staging and endoscopy can be safely pursued, as Dr. Siddharthan, you mentioned, with multidisciplinary coordination. And lastly, treatment sequencing is highly individualized, and patient buy-in, patient input is highly important in these complex decision points. And also patients' values and goals need to take priority as well. Overall, I just want to say thank you so much, Dr. Siddharthan, Dr. Cohen, my colleague, Dr. Allen, for joining us in this episode. And thank you to all listeners who tuned in. And of course, thank you to Behind the Knife for hosting us. Be sure to dominate the day.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple iOS and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.